Welcome to Live Well with UCI Health. I'm Gina Grad with 98.7 and iHeartRadio. I'm here today with Dr. Rebecca Sauer, board-certified obstetrician and gynecologist at UCI Health Women's Health Services. And today, Dr. Sauer will tell us all about menopause. She's going to tell us what it is, how its symptoms are treated, how to navigate the challenges. Dr. Sauer, we are so happy you're here. Thank you for joining us.
Thank you so much for having me here today.
Our pleasure. So as somebody who is kind of trying to figure out, like, am I in perimenopause? What is perimenopause? Do I know what perimenopause is? We have a lot to cover. So what is menopause? Let's just start from the very beginning. What is it? What are the stages? What age do people usually go into menopause? Is there an age we're all waiting for? Does it happen for different people at different times? Tell us everything.
I want to preface menopause and perimenopause with that it is a largely very individualized experience for people. But when we look at average definitions, because I think that helps sets the stage, menopause, at least from the medicine background, is defined as 12 months without a period. And this is naturally. So if you've had a surgery that removed your uterus, or treatments that stopped your periods intentionally or unintentionally, it's a little bit of a different definition. Right. But in general, for an average individual, it's 12 months without a period. Perimenopause precedes this, and this can be interpreted also in a lot of ways.
Yeah, this is a very gray area, isn't it?
Absolutely.
I'm still trying to figure out where I'm at with this.
There's a lot of ways to look at it, honestly. In the whole research area, they have tried to standardize it to make it easier for comparison. Okay. We have a lot more studies in menopause than in perimenopause. So trying to figure out how we can make it equal and relatable and comparable is important. So a lot of perimenopause from the research perspective looks at your timing of periods. Okay. So once you start having some mild irregularities in periods, variations about a week, early, a week late, could be early perimenopause.
Okay. And is a lot of that sort of fine-tuned and figured out through blood work, or is it how much can we nail down perimenopause?
It's a really good question. So unfortunately, unlike a lot of medical conditions, blood work is not very reliable for perimenopause. Okay. We can use it to help us sometimes in those scenarios where we can't rely on menstrual cycles. Mm-hmm. But I would consider menstrual cycles as a pretty important vital sign in terms of knowing where you are in the reproductive axis. Okay. But blood work can give us sometimes a clue. But the problem is when you look at the reference ranges, like that little sidebar that has what is normal. Oh. It's like 50 to 500, and it's like wild. And if it's in a normal range, it doesn't necessarily mean that you're not in perimenopause.
Right, or that it's normal for you.
Right, exactly. Yeah. So unfortunately, we don't have anything that we can reliably use as a one-time test to confirm it.
Okay. So let's talk about the basics. Let's say somebody's coming in and they don't know what's happening to them. What causes menopause?
So when we look at the reproductive function, there's a lot of communication from your brain to the ovary. Okay. The brain secretes a hormone called follicle-stimulating hormone. Okay. And it's trying to get your ovaries to spit out an egg or ovulate. So when that brain communicates to the ovary, your estrogen levels increase until you ovulate.
Okay.
As we start to approach perimenopause and menopause, our ovaries are running out of eggs. So our brain is working harder and harder to try to get that same level of estrogen response that it was before when we were in our 20s and 30s. And eventually, your ovaries are no longer ovulating, so the brain is very hyperactive. And that's why we get a lot of central brain symptoms. It's because a lot of the overactivity of the pituitary gland trying to get your ovaries to ovulate. And eventually, the ovaries is what secretes estrogen, and that will eventually decline. And once that ceases to function, we're in menopause.
Okay, so like the book says, it starts with an egg. And so the egg sort of controls how much estrogen is released and how it's released. Okay, and roughly, I mean, within 10, I'm kidding, but roughly how many eggs are we born with?
Oh, like millions, yes. We have the most eggs when we're actually infants in our mother's womb. Right. And it starts to decline. And then once we're in puberty, then we start to release the eggs more regularly, and then it starts to accelerate after in our mid-30s to 40s until on the average age of 50.
Got it.
No more.
Okay. So when it comes to all this stuff, there's, the synthetic hormones, there's the bioidenticals, there's all kinds of things we can do. What about food. We hear all this stuff about what we can control, which we know is not much, but we can control our diet. We can control our food. And we are getting inundated with protein talk. I feel like the cycle has come around again where everything's protein. Take your weight, divide it by 2, multiply it by 7. That's how much protein you're supposed to have before noon. Like, how important or unimportant is protein?
It's a really good question. We do see a lot of metabolic changes in midlife, and we lose muscle mass more rapidly, especially as we enter the time that most of us are entering perimenopause and menopause. There's also changes where we get more insulin resistant too. So there can be sugar changes as well. So to kind of help stabilize that or optimize it, honestly, a well-balanced diet is the most important that incorporates protein, but also fiber. And I want to think like just longevity. I'm a little bit cautious about these really high protein requirements that are the sole thing that perimenopause and midlife women need. Some of these numbers that we see are kind of like extrapolated from what we use in critically ill patients in the hospital and their protein needs, which in certain medical scenarios may be applicable, but probably not for the average perimenopausal patient.
That doesn't mean that I need to go on a carnivore diet tomorrow.
No. Okay. Honestly, and from a longevity standpoint, we want to think well balanced. Like make sure you're getting your fiber, make sure you're getting your macronutrients and all the other kind of vitamins and micronutrients that come in all sorts of food.
Okay.
So I think that overall is the safest option. I think we don't have enough information about the long-term effects of very high protein diets alone for perimenopause in terms of its health impact.
Okay, so incorporate it, don't live by it. Or as a nutritionist friend of mine used to say to me, stay on the perimeter of the grocery store. Don't go through the aisles with all the processed stuff. Stay at the deli, stay at the butcher shop, stay in the produce.
That's right. That's right.
Okay, so that makes sense. Now, I was told a while ago, and I never really double checked it, I just stopped eating it. I love edamame, and I used to put soy milk in my coffee. But I'm kind of off of soy because I was told that it's estrogen heavy and it can mess with women. Is that true?
The estrogen activity of soy is very, very weak.
Okay.
So I think when you look at the whole context of everything, the hormones circulating in your own bloodstream are going to be much more potent than what some soy milk or edamame can add to. So overall, I think there's a lot more health benefits in those foods as being, offering a lot of micronutrients and fiber and, protein and other sources of, nutrients.
Yeah.
And then the risk of estrogen is extremely low.
Okay, so even if I'm ordering like 2 garlic edamames for myself and like the shells are up to here, I'm not doing real harm to my body.
No, enjoy it. It's probably better for your health to do that.
Oh, good. I have a plan for tonight. Okay, so that really helps people understand because like you said, there's so much misinformation and we don't want to do it wrong. So by telling us, everything in moderation, keep it well balanced, don't be afraid just for being afraid's sake is very helpful. But when it comes to being cautious and we talk about like third-party services, I'm curious I guess everything's allowed if you know the right person, but what is allowed? And people even talk about testosterone therapy. And you wouldn't think that a woman needs testosterone, but that's probably important to a degree. So can you just talk a little bit about both of those things?
Yeah, I think there's a lot of ways to look at it. I always preface that I have an MD, so I trained in allopathic medicine. So this is my bias and this is my background.
Sweet.
And there's lot, right? There's a lot of ways to approach health. And I think there's a growing body of people going into more functional or naturopathic and integrative medicine. And these can oftentimes collaborate with each other, but also there are some differences and variations in the way that we approach things like midlife care. So in my perspective, I think finding someone who, I think it helps when people are certified from like the Menopause Society. Again, not necessary to be a midlife provider, but kind of helps knowing that you're getting what's evidence-based care, standardized practices, expert opinion, people that have done a lot of research and created these suggestions and recommendations. I think that can help provide a little bit more security and you're getting what you're getting.
And I'm glad you said the Menopause Society because my doctor's part of that and I only heard of it a few months ago. So it's a real thing.
It is a real thing.
Amazing.
Yeah. You mentioned testosterone therapy. That is actually, so I think one of the common symptoms that we see in perimenopause is low sex drive. And there have been really good studies that looked at perimenopausal and postmenopausal women. And low-dose testosterone therapy can be really helpful in alleviating that very distressing symptom that women can experience in perimenopause and menopause.
So both men and women have diminished testosterone as they age? I did not know that. Okay.
So testosterone is released primarily from the ovary in women, and that also declines as we enter perimenopause and menopause.
Okay.
And that can affect that. So to back up, sex drive in women tends to be very complicated and multifactorial. So I don't want to say that testosterone is the only thing that is going to be the issue or the fix. Women are complex creatures, I'd like to say. Aren't we, though? But it's multifactorial. So it's important to address, like, you're feeling good, you're not stressed, that there's no other medications that may be having a negative side effect. But low-dose testosterone can be a really good option for women experiencing low sex drive in perimenopause and menopause.
Is testosterone considered part of hormonal replacement therapy?
So unfortunately, there's nothing that's FDA approved for women for testosterone.
Why? Rhetorically, why?
Not a priority of the FDA to move that through, unfortunately.
Got it. Okay.
But we have, there are societies and expert opinions, because there is a relatively robust amount of studies done on this already that have recommendations in prescribing it off-label or potentially using compounding pharmacies to create prescriptions that provide low-dose testosterone for women.
So what should we, if this isn't something that we're going to get a prescription for, what are the cautions? Is this something we go to a vitamin store and be like, give me your testosterone vitamins? I mean, what do we do?
Yeah, no, it's a really good question. So I do think talking to your healthcare provider about it, because there are guidelines and there are recommendations based off expert opinions and international societies that we have. And then testosterone is a little bit different than the female hormone replacement therapy, because we don't have a standardized product for it. It's something that we do have to follow with blood work to make sure that it's in a safe level. So you want to make sure that you're under the care of someone who has experience in terms of monitoring this as well.
So you can get an abundance of guidance from a professional, even though they're not going to write you a prescription for it.
You can. You can.
That makes a lot more sense. And I didn't know I needed to put testosterone on my shopping list. So thank you very much.
You're welcome. There's a lot out there, and I think it's very individualized what combination of therapy, if any, is right for a person. So knowing your symptoms well, and then working with your healthcare provider to find out what the best therapies are, because we talked a lot about medical therapies, and I think they're highly effective. And there's just so many lifestyle changes we want to be aware of as well, whether it comes from sleep hygiene or exercise or strength training. There's a lot of things that are cognitive behavioral therapy. There's a lot of resources and a lot of ways that we can improve quality of life. Yeah,
and like you mentioned exercise, and I'm one of those people that I hate exercise, but I love to have exercised. So in that case, I don't know if you know this, but exercise sometimes has benefits for your mental health. And I know that building muscle, because we lose it so rapidly in a certain age group, is important. But if somebody says, look, I love to walk, I'm a big, power walker, but that's all I'm willing to do, I would imagine that that's significantly better than sitting on the couch, even though they're not strength training.
Absolutely. But when it comes to strength training, it doesn't mean necessarily getting, weights that are 3 times your body weight. Even body weight exercise, whether it's, like push-ups or squats or even without any extra weights, beneficial for bone health.
Love it.
So it doesn't have to take a whole lot in order to do big things for your bone and muscle strength.
That's what they say, perfect is the enemy of good. Yes. Like, I think a lot of us just say, you know what, I don't know what I'm doing, and I'm not going to, be a clean and jerk bodybuilder, so I'll just forget the whole thing. But we actually can do things, and it will make a difference, and we'll feel better.
Yeah, you don't need a gym, you don't need weights to do strength training to protect your bone health.
Okay, so let me just elbow everyone else out of the way and get personal, because I have an expert here. So I was trying to figure this out with my doctor, and long story short, she ended up putting me on a birth control patch. And she said, now, everyone wants the standard HRT and the hormone therapy because that's what we hear all about these days. But she was saying to me, I don't think you're really a candidate for that right now. I think, and a lot of women for some reason resist this because it just doesn't seem like it makes sense, but you'd be better off with an estrogen patch or a hormone or a birth control patch. Does that make sense to you?
I think that is certainly an option. Whether that is the only option, I would, debate, because I think there's pros and cons to each approach. It's very reasonable to consider something like hormonal contraception for someone who has not reached menopause.
Because I am not worried about getting pregnant. I think we're past that.
If we're worried about contraception or, sometimes with menstrual irregularities that are bothersome, then we may get some more benefits from being on something like birth control.
Just to make it more, we can sort of set our watch by it.
Exactly.
Okay. That's fair enough. And what are the typical, and we'll stick with menopause right now instead of perimenopause, because like you said, that's a wide swath. What are the very typical symptoms of menopause? I mean, we've seen throughout, if you watch Sex and the City or sitcoms, it's always a hot flash. You're always sticking your head in the freezer. What else is there?
Yeah, so when we look at the most common symptoms associated with menopause, hot flashes and night sweats, things we call vasomotor symptoms are the most common. Sleep disturbances, mood changes, whether it's more depressive, anxiety, irritability, almost like exaggerated PMS can be seen as well. So definitely mood changes can be observed in perimenopause. There's sometimes an analogy between like postpartum and how there's a risk for postpartum depression and anxiety. With perimenopause, they're considered windows of vulnerability. So we recognize there's a big tie between female hormones and mood. Urogenital changes, so changes with like vaginal dryness, bladder changes, incontinence can be seen as well. Joint pains can be seen, so things like frozen shoulder, musculoskeletal aches and pains, knee pain, elbow pain, wrist pain, hand pain.
That's wonderful.
I can keep on going. I going down the road.
This might just be like a TikTok thing and an Instagram thing, but I kind of check in with what the ladies are talking about, and a lot of them say, does anyone else feel like not only is their skin crawling, but like their ear is really itchy? And I swear to God, I thought I was losing my mind. Have you heard of these symptoms?
I have. Like, we have seen anything from visual changes, ear changes, skin changes, not only, thinning and cosmetic changes, but things like itchiness or even like hives and eczema, rashes. Pretty much every organ system that you can think of may have some relationship with the female hormones in perimenopause and menopause.
But like all the memes say, you haven't seen real pain and suffering until your husband has had a cold. But we're the ones that put up with everything. And so it makes sense that you're talking about if something is happening to you and you're not sure what it is, and that's kind of the season of life you're in, there's a very good chance you can track it back to menopause.
There's a lot of correlations. One, the way I approach menopause and perimenopause care is because we don't have a way of clearly identifying that your symptoms are related with perimenopause. And also, it's usually a time period for women where health conditions may put them at risk, because we do see that things like thyroid disorder, autoimmune disorders predominantly affect women. Right. And this can pop up in midlife too. So just making sure that we're ruling out anything that could be an endocrine issue or, an arthritis issue, autoimmune, because these do predominantly affect women, is really important. Not saying that someone's symptoms are in their mind, but also just doing due diligence to take a holistic approach to your health. So I find menopause is a really good opportunity to be preventative. Let's look at your health. Let's look at the risk factors that you may have, the potential conditions that you may be at risk of, and also alleviating your symptoms that may be happening as a result of menopause.
And that's refreshing to hear, because, I think as women, we're just used to like, I don't know, probably menopause. Watch your weight. That's all you ever hear about.
Right. It's just a part of life. Suck it up.
Exactly. You're not the first one to deal with this. You won't be the last. In your experience, I don't know if there's, I'm sure there's research on it, but even anecdotally, what is the youngest and oldest patient you've seen go through menopause?
That's a really good question.
I'm very curious.
I mean, so when we look at averages, the average age of menopause in the U.S. is between 51 and 52. Okay. But I have women menstruating all the way up to nearly 60. And then also women who go into menopause in their 40s. So there's a broad range of still what can be considered normal. Right. And then before 40, it's considered premature ovarian insufficiency. So same kind of hormonal issues, but in a category where much less common.
That makes sense.
So really, at any age, if you look at that under different names and diagnoses. But there's a huge spectrum.
And so if we're just talking about, world record holders here, what's the average amount of time that someone's in perimenopause, and how long can that go on for?
So again, I think that's so individualized because there are some people who their period stopped and they're like, oh, I'm in menopause.
That's that.
It's the next phase of my life. That's not the most common presentation at all, but there are certainly some individuals who will experience that. And we have seen that menopausal symptoms in studies have lasted, on average, 5 to 10 years for individuals.
What?
So that's the average. That means some women a little less, but also some women potentially more.
Wow. That's okay. I don't know if I look forward to that or not.
Right.
And you said, that a lot of times this is sort of an underfunded, understudied area. Why? Why is it that doctors and especially gynecologists seem to know so little about it, or I don't know, give much less credence to that as they would something else?
Yeah, I know. I think we do see this. I do a lot of leadership for the third year medical students. So I see what the curriculum and what's emphasized on their exams and what they're expected to know. And in women's health, there's a lot of emphasis on obstetrics.
Sure.
There's a lot of obstetrics on kind of younger reproductive age topics, contraception, abnormal bleeding, endometrial, things that certainly warrant attention. Right. But that's all it's not a lot of adolescent stuff and a lot of menopause care.
Right.
They're not expected and not really emphasized to know that. So that trickles down. It does ends up trickling down.
And it boggles the mind, and it makes women over 40 feel so invisible. And it's like we're still useful. I started going to a different OB-GYN because it became so clear to me that she was so focused on obstetrics, and that just wasn't something I needed.
Yeah.
So I felt like I was just at the wrong doctor.
Yeah.
So that does happen, and I guess, like you said, it starts with education.
It does start with education. So we're certainly making moves, and I think there's even talk that this needs to be a fellowship. People need to be trained extra in order to become experts in areas of menopause care.
Absolutely.
I've even seen things on conversations about splitting up women's health, because it's become so complex and so diverse.
Sure.
That 4 years to cover OB-GYN is just not enough.
Absolutely.
So we need to really focus. Some people may just need to go down the gynecology track and take care of, that, and then focus on obstetrics.
That
and
would be
I am
awesome.
Understanding that because
and
it's
consider
complex.
that a 35-year-old's considered a geriatric pregnancy. It's like, let's get a different word rocking, people.
Yeah, no, absolutely. So I do think there's just so many opportunities for teaching and education and
You're so
training.
right. That makes so much sense. Which interest, are you going into in OB-GYN? Because like you said, people just focus on is she pregnant? Is she not pregnant? And we're just so much more than that.
We are more than that. And studies have actually shown that. When you enter menopause, you still have a third of your life ahead of you, right? It's not like it's over.
No.
And these are women in their highest point in their careers, most productive. And menopause really diminishes their ability to work sometimes and
we're
be productive.
outliving men.
Yes.
So we're gonna be here whether you like it or not.
Yeah.
You might as well let us schedule an appointment.
From an economic argument where it's there's a burden for women experiencing menopause if you don't address it or research it or study it. Or just from, cultural standpoint, investing in the future.
Absolutely.
There's just a lot of avenues for, I think, or reasons why we should be looking at this more.
Absolutely. So let's talk a little bit about HRT, about hormone replacement therapy. Now, for some people, it's discouraged. It has been discouraged in recent years, and that's it's re-entering the conversation now. And like I said, it's sort of, for lack of better words, trendy. It's popular for women, in their mid-40s to start asking their gynecologist, so what about HRT? We're sort of fishing in the dark here going, okay, that's something I'm supposed to ask about. Well, where are we with that? So why would that even be controversial?
So I think it all stems from, if you look at the history of hormone replacement therapy, initially, I think one of the concepts was we noticed women were having heart attacks after menopause. So what if we just give the hormones back? Is that going to protect their heart health? And then when you started it, women felt great. They were like, wow, I feel amazing. So the prescription for hormone therapy exploded, and then they started to do more formalized studies. And there was a large study in the 90s, the Women's Health Initiative, that was stopped early because there was an unacceptably high risk of breast cancer. And again, it wasn't the absolute present risk you're going to get breast cancer more often than not. It was higher than what we expected.
Really?
So it was stopped, and that was the most publicized part of that study.
So I don't want breast cancer. I don't want HRT.
Exactly. So everyone stopped prescribing it.
Got it.
And it's taken a long time to realize that there's so many differences now. The medicines that we prescribe are not the same ones in that study.
Right.
There are also some large flaws in that studies or way to look at it that just may not be applicable to you as an individual person.
Right. Well, it's like saying there were issues with Prozac. Well, that was 30 years ago. We have all kinds of options now.
Right.
And talking about different options, I wonder how many times a patient will talk to you about something that I only know about because my mother and her friends, bioidenticals and the plant-based stuff. Do you have any thoughts about that? Again, this is a personal question because I've heard this term so many times.
I think it's a really good question because I think there's a lot of information out there. And the way to there's a couple ways to look at the prescriptions that are out there. Bioidentical versus synthetic is the way to look at it. And what bioidentical means is that the medicine, the chemical structure of the medicine looks like the hormone in our bloodstream.
Okay.
So if you look at the chemistry of it, they look similar.
The little circles and lines.
Exactly, the little circles and lines,
right?
To know. Versus a synthetic hormone can bind to those receptors, but it looks different. So it has the ability to be stronger potentially than it needs to be.
Okay.
And then those are some of the hormones that we often use in like birth control or other hormonal causes.
Okay.
So bioidentical versus synthetic are just the way it acts on the receptors in our body.
But you don't look at like one as good or bad.
I would say, so that's a really good question. I think the newer studies are suggesting that the bioidentical medications that we have, which are FDA approved, they've been studied, they're regulated, are probably less risky than the synthetic hormones that we have.
Interesting. Wow. Okay, because I know for a while when people would bring that up, they were kind of laughed out of the room. Like, that's not, or you think it's plant-based or whatever, so it can't be strong enough but you're saying that's not true.
So the bioidentical it's commercially available. It is FDA approved. Because I think there's this concept that bioidentical has to be specialty made or compounded, which is another term that's commonly used. Compounded medications are not generally first-line preferred because there can be a lot of variability in the concentration. But you can get bioidenticals, from your CVS. That's a prescription and available.
So you're saying that a lot of that, like a lot of medications now, and again, compound pharmacies, I think most of us hadn't heard of until we all started GLP-1s. But they're regulated. It's not like somebody's making it in their bathtub.
Right. Correct. But again, studies have actually shown with the compounding ones, there can be a little bit more variability. The FDA-approved ones have to have a very strict standard of concentration and purity. So again, not a no, but not preferred.
Got it.
It's like first line and second line going down.
That makes perfect sense. And so talking about, those kind of things about the replacements and the bioidenticals, what else is there? Are there other treatments that we're not aware of? I'm sure, I'm hoping there are.
Yeah. So hormone therapy, I think as a class, there's a lot of different nuances and variations that can be prescribed within the bioidenticals. There are synthetic options. There's even a class of medicines called selective estrogen receptor modulators.
Hold on.
SERMs, yeah. So those work on binding to some receptors, but not other hormone receptors in your body, correct? And depending on like your medical history, some may be better for you than others. But those hormone medications basically work on the hormone receptors in our body. There are non-hormonal options as a class too. And these can be really effective in alleviating symptoms, particularly in someone who it may not be safe to do hormone therapy. For instance, people who have been survivors of hormone breast cancers or hormone positive cancers in general, or people who are predisposed or have had a history of blood clots in the past. So those could be reasons why hormone therapy may not be the safest option as a first-line therapy.
And then they would do what?
Non-hormonal options.
Okay, so we're not talking, I don't know what I thought you were going to say. Go take a shot of wheatgrass. Like, we're not talking about that. We're talking about stay in the same class.
Exactly. Okay. So there are options. There are 3 medications currently that are FDA approved for menopausal symptoms. They are medications that work on essentially neurotransmitters or hormones in the brain.
Okay.
They can help decrease hot flashes, help with sleep. One of them is kind of a cousin, I would say, with an antidepressant.
Really?
Paxil, yeah. So it's been also to help with the mood symptoms.
Oh, that makes sense.
We have a lot of studies for women who've had breast cancer, and it's not safe to do hormone therapy. So they've been on other antidepressants, like Effexor has been studied a lot. And has shown benefit for quality of life. So certainly there are a lot of, and then there's like a whole host of other medications that are used off-label to help improve quality of life.
Okay, I am so glad you said that because, again, I get all my information from random chicks online. There is something going around, and I've got to know if you've heard about this. Now, this is mostly for PMDD, or they say, just really bad, menstruation. Have you heard about this little combination? You know what I'm going to say. Pepsid, like a heartburn medicine and an antihistamine. What is going? They're like, oh my God, it's a miracle combination. Why am I just finding out about this? And I am so curious. I'd love to get a real expert's point of view on that.
I will have to say, anecdotally,
yeah.
I have seen it as well. But from a patient perspective, I haven't heard any cases of anyone either actually trying it yet. But I look forward to it. I'm very curious. But from the evidence perspective, there certainly is a link with histamines and hormones. But whether hormone therapy or whether that's actually a clear link or a good therapy is I think still not really well described or determined.
Well, and also it's funny, but also how sad is it that this is how women are exchanging information because, sometimes that we feel like that's all we have to work with.
I think that's just a big reflection on healthcare not moving fast enough to meet the demands and answering the questions for women.
Yes.
So women are looking to other sources and finding, and then there are companies who are taking advantage of this and creating these health opportunities to prescribe hormone therapy, to, do X, Y, and Z for women. But what I feel is important and less trendy and less cool about menopause is that it's a window for a health opportunity just to make sure what can we do to protect your heart health? What can we do to protect your bone health? What can we make sure that you have the best third of your life coming up? There's a hormone therapy, which in a lot of ways, or medical therapy. I'm just using hormone therapy as an analogy since I feel like it's popped up in the community a lot as a, just schedule a visit online, we'll prescribe your hormone therapy. And while I agree that it's a great resource for women that they're getting help in the immediate term, I think it's also important to realize it's important to look what your next third of the life is going to be and what can we do to make that the most productive, healthy, happiest time coming up too. So I think that's where physicians are good at. We just need to be able to combine the two, address, feel comfortable managing menopause symptoms and then also continue on with that healthcare.
You are so right about that. And when you talk about, it's really sticking with me about how you're saying this is a whole body issue. This isn't just, where my uterus is. This is a whole body issue. And part of that body is the belly that a lot of women say I've done everything. I'm starving myself. I'm working out like you wouldn't believe. I haven't eaten a carb since my last birthday. But what is it about menopause and that menopause belly that just doesn't seem to budge?
Well, there certainly is a scientific explanation for that.
Okay.
So it's not in your head.
Okay.
We do see that with aging and in our 40s and 50s, that metabolism slows down in both men and women. So in general, if you look at thousands of men and women, everyone does gain a little bit of weight, lose muscle mass. Mm-hmm. So those changes happen. But we do see that for women, there probably is an estrogen receptor etiology going on in the belly so that there tends to be a more central gain of weight gain, which I think a lot of women experience and feel. So there definitely isn't a hormone effect in that. We also see that a lot of menopausal changes, like when women are experiencing hot flashes or disturbed sleep, your body's in a state of fight or flight. It's not going to release any weight. You can starve yourself, but your body's signaling I need to save all my resources right now. I don't know what's going to happen.
Something's happening to me.
Exactly. Yeah. So we need to get your brain to just be okay, you feel okay. Let's improve your sleep. Let's improve your hot flashes. And then a lot of times women will experience that, the efforts they're making with lifestyle changes, exercise and diet are finally starting to pay off.
Okay.
Hormone therapy isn't studies have shown that it also slows down weight loss. And then there has been some studies that show a little bit of mild to modest weight loss with it. But I would say it's not really a promising weight loss therapy.
Like you said, when you're addressing these other issues, especially you get put on an antidepressant that makes your brain, the juices relax.
Yeah.
I think that was a medical terminology that I just used. That your body doesn't have to live in this, something's happening to us and we need to panic.
Yeah, yeah.
And when you say, disrupted sleep, I still don't know if this is real. I feel like I have it, and I don't know if this is real. My mom is 100% sure she has restless leg syndrome, a term that I feel like in the last 5 minutes has overtaken all of our lives. Do you think that's a real thing? And could it be related to menopause?
Yes, I do think it's definitely real.
Okay.
And there certainly are some associations with those kind of nerve skin kind of sensory changes with menopause as well, sleep disturbances. And, it's hard because sleep disturbance is so broad.
Sure.
Right? Sometimes it's hot flashes waking women up. Sometimes they're waking up in the middle of night to go pee. Sometimes they just can't get back to sleep once they do wake up. So there's a lot of variation too. Or restless legs is preventing them from falling asleep. So it's hard to really pinpoint exactly the sleep, but it certainly is affected.
Yeah.
Whether it's directly from menopause or from other complication or symptom of menopause.
Well, and I have to take my own advice. I go, get off your phone and put it down and stop with the blue light at midnight and that being the only light source in the room. I mean, we're all guilty, but I do I get, as they used to say on Seinfeld, I have the Jimmy legs. I just can't stop moving. And I was like, I don't even know if this is real. But thank you for validating that. It's helpful.
No, I think, but you know what? You bring up a really good point. And I feel like a lot of women are told or kind of suggested that it is kind of not a real symptom. It's like in your head.
We are bred to second guess everything that happens to us.
And I think it's really important. I think why this has moved so far is that women are speaking up.
Yes.
And saying, this is real. This is my lived experience.
Yes.
And menopause is unique. Who are we to say that this may or may not be? And I think we need to look at it more so that we're able to do more studies, get more answers. We have a lot to do, but certainly what I'd like and I appreciate are my patients speaking up for themselves and advocating.
Now, I'm so glad you said that because, we've, kind of a common thread through this conversation is feeling dismissed, feeling ignored. I always say, if you need me to be your advocate, there's no one better. But if you need me to be my advocate, that's where things get a little dicey. So as a professional, what advice can you give to us to best advocate for ourselves in these situations?
Yeah.
First of all, I don't want to feel like I'm nagging. I don't want to be annoying. All these things go through our heads.
Don't wait too long. Okay. I think what I see with women and a common thread is that they are oftentimes busy taking care of their household, their children if they have them, their work, possibly sick parents, and they put their health on the back burner for way too long. And they're suffering and they're miserable. Yeah. And I think just to carve out time for yourself, make yourself important. Remember that if you are not functioning well,
everything around
society
you
around you is not going to either.
Totally.
So prioritize your health, and it's okay to speak up for yourself. And what your symptoms are truly real, and it's individualized. So what you're experiencing is specific to you. So feel free to talk about it and bring it up to your healthcare provider.
That's such great advice. Don't put yourself last because then you're going to suffer. And this is just a completely anecdotal question. And I had an amazing male gynecologist a few years ago, and he was just a godsend for me. But in general, a lot of women do not feel comfortable going to a male gynecologist. And I'm wondering, do you have any opinion on men in this industry being more dismissive, or do you think they understand that women really need to be taken seriously by an OB-GYN?
It's a really good question. I think we are obviously seeing that women predominantly are becoming women's healthcare providers. If we look at our residencies and people applying it as 90% women have not. So it's very much going to be heavily
for sure.
Yes. But at the same time, I've heard it both ways. I think, men can be obviously very compassionate and very understanding, and some of the most understanding healthcare providers. And sometimes there are also women providers who are like, I did it. I sucked it. It's not a big deal. You're going to be fine. Yeah. Which is also not appropriate either. So I've seen it both ways.
Okay.
But it is a very, women and men do live very different reproductive lives.
Yes. And I'm just curious about that because I know some people would be skittish, understandably, to go to a man, but I really have had a wonderful experience as well. So I'm just curious. So speaking of men, if you have a boyfriend, if you have a husband, and he just doesn't know how to support what you're going through because you don't even understand it, how are you supposed to articulate it? Do you have any advice for them when they're trying to support a woman going through perimenopause, going through menopause? What advice do you have for them?
I think there's a lot of ways to be supportive, but the first thing is really educating and understanding the individual symptoms and kind of the way that women may experience perimenopause. So just being mindful that this is a transitional point in someone's life. So this is not reflective of who a person is.
Right.
They're not necessarily like changing or transforming into a different person, but they are going through a lot of physical, hormonal, mental changes at the same time too. So I think open communication is really helpful. Like, what can I do to help? Whether it's being an advocate to make sure that your, woman is seeing a healthcare provider.
Right.
And being able to self-care and prioritize her health. Or if it's like hot flashes, making sure she has her fans and the temperature is set,
Oh, that's the neck fan is the best invention ever.
And just really being mindful, because I get a lot of women who feel bad about themselves because they're like, oh, my partner is like, what's wrong with you? Like, you're irritable. Like,
you're not the person
you're
I
gross. You woke up
married.
sweaty.
Yeah,
and then it's
right.
like, it's no fault of your own,
Right.
just to kind of be there with the changes. Would be my, it's not very well said, but that would be my best
trust me,
advice.
it is very well said. And I would also think that a part of that would be like, don't take it personally.
Don't take it personally.
There's this guy, he's a comedian online, and he just kills me. I wish I could remember his name, but he goes through a list like every week of all the things that his menopausal wife has told him he's doing wrong. I chew wrong, I breathe wrong, I sleep wrong, I talk wrong. And I think there are these sensitivities, we, like you said, we can't control it. We're riding these hormones like everybody else. And just like whether she's menstruating or she's in perimenopause or menopause, like, don't take it personally. Sometimes you just breathe wrong and we'll get over it and we're sorry.
Yeah, exactly. And I think it's just that understanding and open communication that's really helpful.
I think you're so right. Do you ever see patients, do they ever come in with their spouse? Is that normal?
You know what? To be completely honest, I do see it, but I would say the more common is that like women are in between picking up their kids and taking them to, and they're squeezing in the last minute. So yeah, that's what I more see.
Because when my husband and I first, were in like a relationship, I told him like, oh, I have an OB-GYN appointment, next week. He's like, oh, what time? And I'm like, what do you care? He's like, well, do you want me to go and support you? I was like, oh, no. But that's so sweet.
That's fantastic.
I just didn't know if like people did that.
Yeah.
No, I absolutely not. I'm good. I just thought that was really nice. I don't know if
I certainly do see it. And I've seen some great examples of support from families and partners. But I think more often than not, women are coming in last minute for their health.
And we got this.
Yeah.
Well, you have been so informative and inspiring, and I just appreciate you taking the time, Dr. Sauer. Thank you.
Thank you so much.
I hope we can do this again. I have so many more questions.
Let's do it.
Please. Thank you.
Wonderful. Thank you.